we are welcoming Dr. Helen, and I think she is going to give us a lecture related to the regenerative medicine for management of degenerative spines, which is new in the anesthesia fields. Dr. Helen is an anesthesiologist and consultant of pain specialist at ASA Pain Clinic in Tehran, Iran. And she received her MD from the University of Medical Science in Mashhad and completed her residency in anesthesiology at Uremia University School of Medicine before fellowship training in the Interventional Pain Medicine at Tehran University of Medical Science, Iran, and Texas University in USA in 2012. Dr. Helen focused on the minimally invasive chronic pain procedures for medically challenging patients. And she is an international trainer and researcher and known as a pioneer of ultrasound-guided spine injections and inventor of the Iran techniques. Dr. Helen research interest in the safety of pain procedures and their availability in countries. And her recent book is Clinical Pearls of Interventional Pain Management, which is very important for all the anesthetists, especially who are interested to work as a pain interventionist. It's a comprehensive review for pain fellowship examination and have been very popular in the world. And she is now writing her second volume of the book at the request of the readers, Problem-Oriented Pain Interventions, Preparation for Oral Pain Fellowship Examination. And her recent project is to introduce, which is very, very innovative, introduction of dextrose prolotherapy as a safe and cheap therapy to decrease the incidence of chronic pain in low-income countries. You're welcome, Doctora, and time is yours.
Thank you, Dr. Thank you for the introduction. I'm really proud that I'm here again in Mega Online series. I record a video and I ask you please to play it.
Thank you.
Hello, my dear friends, colleagues, and students. I'm really proud to have been invited to this conference, and I hope this lecture, ultrasound-guided regeneration therapy for degenerative spine disease, help you to use it practically in the patient bedside and help for relieving of your patient pain. Do you hear anything about how a home result regenerative is cut tape? This is the base of regeneration therapy in human. Look at this video. Regeneration therapy is a kind of pain therapy that involves the stimulation of an inflammatory healing cascade by injection of a solution. And this has a long history from ancient time when Hippocrates for the first time used a hot poker to treat dislocated shoulder joint. And then term of regeneration medicine started in 1992 as a branch of the medicine will help to attempt to change the course of the chronic disease. This is very important because our patients and we also tired of symptomatic therapy. We want to return the damaged organ to its natural shape. And there is a revolution in regeneration therapy. It starts with the prolotherapy, importantly, dextrose hypertonic in 1950, and although the mechanism is not clear, but the growth factor increased, collagen increased, inflammatory cascade decreased, and what happened is repair of the tissue. And then they, as you know, human being always search for more effective therapy, and they found that PRP has more growth factor, so why don't use the PRP? And they use PRP for regeneration therapy and revolute it to different type of PRP, leukocyte-free, leukocyte-rich, to increase the efficacy of the PRP. And then they found in 1998 that really why we don't use more potent cell, like pluripotent cell, like a stem cell. And in 2007, actually they found it is not cell that which work. It is the vesicle which have separate substance that is useful. For example, exosome. And exosome is the base of the stem cell. So they use exosome in 2007, and you know exosome have mRNA and genetic material. So why then don't use gene therapy? And we are very lucky that live in 2020 because it's come to practice. And it is really the future of the regeneration therapy. As I told you, we have an inflammatory cascade. It has three overlapping phases. First, the phase is producing an injury which was a constriction, platelet aggregation. It lasts a few days, and then we have proliferative phase. We have a granulation tissue formation at this phase, wound contraction, and finally we have remodeling phase with change in collagen, extracellular matrix, and it takes weeks to months. And all of this cascade is happened during regeneration therapy. You know, spine consists 33 vertebrae from the cervical, thoracic, lumbar, coccygeal, sacral, and each vertebral unit with attachment of the muscle and ligament and adjacent joint. There are 6 joints around any vertebra, and they are all several for serve as a target for regeneration therapy. In regeneration medicine, the goal is to create a favorable environment in which the body can jumpstart the healing cascade, promote repair, and revitalize itself. So it's important to view the entire spine in holistic approach. Look at this video and see during the degeneration, the whole of the spine damage. So for regeneration therapy, you must consider all of the elements: bone, ligament, muscle, and joint. Look at this video, please.
A lumbar spinal disc acts as a shock absorber between vertebrae. It allows the joints in the spine to move easily. The strong, fibrous outer portion of a spinal disc, known as the annulus fibrosus, contains the soft inner core of the disc, the nucleus pulposus. Each person's spinal discs undergo degenerative changes as they age, but not all people will experience symptoms as a result of these changes. Symptoms are most commonly seen in 30 to 50-year-olds. Pain from degenerative disc disease is usually tolerable, with flare-ups that last for a few days or more. It is normally felt in the lower back, but it can radiate into the hips and legs. The pain tends to be worse when sitting, as the discs have to bear a heavier load. One way degenerative disc disease causes pain is through inflammation of the nerves. When the outer part of a disc breaks down, the inner portion of the disc can leak out, releasing proteins that irritate surrounding nerves. Another cause of pain is when degenerated discs cannot properly absorb stress, leading to abnormal movement along the vertebral segment. Back muscles may spasm painfully in order to stabilize the spine. In some cases, the disc space may collapse enough to compress a nerve root, leading to leg pain, known as radiculopathy. Low back pain from degenerative disc disease often goes away with time as inflammatory proteins decrease and the disc collapses into a stable position.
Degeneration of the spine will happen in the aging, natural aging, but it also happens when a patient uses the spine with excessive strain and heavy lifting, for example, labor-intensive job, or prolonged sitting, poor posture, or when there is lack of the muscle support, for example, in obesity, and all of them will cause to degeneration of the spine. So but the mechanism is the same. You can see that end plate thinning, fracture, modic change. You can see end plate sclerosis. You can see facet cartilage erosion. You can see posterior anterior spinal ligament degeneration. And even you can see the muscle fatty change, for example, in multifidus, and all of them will cause the degeneration of the spine and fasten the process. Much of regeneration therapy is done on the intervertebral disc, and in theory, there is cell in matrix that have the capacity to change and reorganize the environment of the disc. Regeneration therapy of the disc is with using of the cell, for example, PRP, stem cell, or with use of cellular therapy, gene therapy, or even more simpler exosome, microvesicle, alpha-2 microglobulin, fibrin sealant, even growth factor, and high-density collagen, all of them inject into the disc and cause remodeling and change of the disc space. I will show you some evidence about this to become more familiar with that. And this study is done in 2014. They used 4 ml fibrin sealant, inject into the symptomatic lumbar disc, and they found it is effective, improved the pain, but they reported 2 cases of the muscle spasm and 1 case of discitis. In the other study in 2010, they used methylene blue and all kind of their prolotherapy and inject into the disc, and it found it very effective and alternative for surgical therapy even. And in other study, in 2006, they used the hypertonic dextrose 25% 3 ml into the disc, and they found it caused pain reduction for 80 months. In other study, they used the PRP 2 ml injected to the disc, and it caused by 50% reduction of the pain in 74 patients, and for 4 weeks started and sustained for 48 weeks. In other study, they inject 1 and 3 ml stromal vascular fraction derived from fat tissue, and they found it has no adverse effect, no complication, and decreased pain for 6-month follow-up. In the other study, 2 patients injected 1 ml human umbilical cord tissue-derived mesenchymal stem cell, and they found it caused in the follow-up, in 2 years follow-up, it increased the disc height. In this study, they inject bone marrow-derived mesenchymal stem cell in 5 patients and suggested that it causes, it's safe and effective during 4 to 6 years follow-up. And in MRI follow-up, they found that the posterior disc height increased and protrusion size decreased. For acute radicular pain, routine care is commonly epidural or transfemoral steroid injection. You know, the result is short-term sometimes and have increasingly been criticized for failure to provide lasting benefit and expose patients to risk of steroid injection. So for better improved outcomes, several clinicians now use PRP, dextrose, and prolotherapy or stem cell therapy in epidural and transfemoral. And evidence for this kind of study is that in this study, they inject 3 to 5 ml platelet into the epidural in 470 patients. This study is done in 2017. Different kind of this protrusion into the extrusion even, and they found that this is during 2 years follow-up, they found that it is good as epidural steroid injection, and it has an adverse effect of it. In other study in 2016, in moderate to severe low back pain, they inject epidural 10 ml, 5% dextrose, and they found it is effective and releasing pain for 2 weeks. In other study, they used the 5 ml epidural injection of the PRP, and they found it is effective for a long time and is alternative to steroid. In this study, in 88 patients in 2017, they use epidural injection, and even also they inject in the lateral mass of the cervical region, passive joint, lateral gutter, inter and supraspinatus ligament, cambic triangle, spinous process, all of them inject at the all of side, and they choose the different patient, even extrusion and in the cervical, lumbar, many different patient, and they found that it is 80% effective in 8 years follow-up, decreased pain, and found it very good. You know, for physical joint injection, there are many controversy about the outcome of the different type of the methods. So today's many clinicians want to use regeneration therapy in the fashion because they want to treat the facet joint, regenerate facet joint. They want to treat the cause of the pain, so they will receive pain relief. They don't want to do steroid injection. And evidence is good. In this study, they inject dextrose glycerin phenol. Glycerin phenol is an old type of prolotherapy, and they use this is done in 1999. But the site of injection that they use is great, and this is really the site that I use today. And it is a spinous process. It is interspinous ligament, supraspinous ligament, apophyseal joint, iliolumbar ligament, transverse process. And dorsalumbar fascia, iliac crest, although they found that injection of this solution with normal saline hasn't no difference, but now you know normal saline is also analgesic. I wrote a lecture about it in Pain Physician last year. And in other study, they inject PRP 0.5 in the facet joint, and they found good and excellent result. In this study, they use intra-articular lumbar facet, and they found it superior to steroid injection in long time. And intra-articular facet joint dextrose for whiplash-related injury is superior to root injection and RF, and is very safe. Injection of the dextrose into the vessel will not cause embolization. What will happen during the steroid injection? I talk about in my first book, safety recommendation for ultrasound-guided spine injection. The steroid very dangerous in the cervical. But when you inject dextrose, there is no problem for that. And the other study, intra-articular facet joint injection against cervical, thoracic, lumbar, and SI joint up to 3 weeks considered safe and alternative therapy. This is a study done in 2021 with my friend, Dr. Edison, sent it for me. They use injection of the into the facet joint, PRP, into the facet joint, the vertebral disc, epidural stage, paravertebral, many sides, depending on the sign of symptom of the patient. And they found it is decreased visual analog for up to 1 year of the follow-up. And there are no adverse effects. About the sacroiliac joint, you know, another cause of the low back pain is SI joint. Today, they use prolotherapy for the SI joint, and the result is great. In this study, they inject 6 injection weekly interval, 50 ml of the glycerin, dextrose, and phenol, as I told you before. And they found it decreased the pain. They inject in the posterior sacroiliac and interspinous ligament, fascia, and joint, all of them. And this is an old study, but done with blind technique, but still the site of injection is great, and I used it. In other study, they use dextrose injection, and they inject into the, you know, this is done with Dr. Hauser, which is really a father of prolotherapy. And they use about 60 to 90 ml injection of 50% dextrose with lidocaine in many sites, sacrotuberous ligament, sacrospinous ligament, iliolumbar ligament, interspinous, supraspinous ligament, sacrococcygeal ligament, depend on the patient, even gluteal peripheral muscle attachment to iliac crest. And they found follow up in 12 months, and they found it is great, relief pain, stiffness, and range of motion. Another study inject PRP and compare with prolotherapy, and they found it is a good, and the body number of injection in PRP is lesser than dextrose prolotherapy. This is more effective. Another study comparing platelet with steroid, and they found it is great and relieve the pain in 3 months follow-up. This is a study of the platelet leukocyte-rich plasma, injection of 5 ml, 2.5 ml at each site of weekly interval in the multifidus muscle, atrophied multifidus muscle, and they found it increased cross-sectional area of the lumbar multifidus during 12 months, and really this technique may decrease the surgery and failed back surgery syndrome, and this is a great study. I will talk about it later for you. And we have also use of dextrose prolotherapy for coccydynia. Injection of the dextrose 25% in sacrococcygeal ligament, found it with tender point, and it is great and reduce the number of the surgery in sacrococcygeal site. And how to perform this procedure with ultrasound? You know, first you have to find the patient with you need to do emotional study, physical examination to find the area of the tenderness and pain. Then you have to know the anatomy, joint, the site of incision, origin of the muscle, ligament, and then you have to know stone anatomy. You have to use acoustic shadow of the bone. You have the contact bone. This is a great point, and then you have to do injection. This is the site of the attachment. In the lumbar region, you know, this is a spinous process, this is facet capsule, and this is transverse process, this is iliac crest. All of them you must consider during prolotherapy of the spine or in any kind of regeneration therapy. This is cervical region. You can see the attachment is in spinous process, in lamina, and in transverse process, and even upper in occiput. And in thoracic region, you can see the attachment is in the spinous process, in transverse process, and in the rib. So in thoracic region, consider the rib. And this is the video of the, you can see the attachment of the ligament. Intertransverse ligament, supraspinous ligament, interspinous ligament, and this is in cervical region. I usually use CarePro to increase my visual distance to see all the elements in one view. For regeneration therapy, first you have to find the site of the facet joint and then change it to transverse view to see the spinous process, lamina, and articular process all in the one view. And then I enter my needle in plane toward the spinous process. When I touch the bone, I am happy because I'm in a safe place. Inject here 0.5 or 1 ml, and then play with the tip of the needle to the lamina, and then play with the tip of the needle to articular process. Inject here, and semispinal cavity go up, move up, and this is a safe technique. But usually you have to check before the injection about aberrant vessel which may be near to the facet joint. But you know, when you use prolotherapy, for example, or regeneration therapy, you are safe. This is not like a steroid injection. You must check at the last of the procedure with the injection of the dye and check with fluoroscopy for intravascular injection. This is dextrose. This is no problem if you inject into the vessel. Just the problem is the injury to the vessel. So be careful, but you can use ultrasound as sole imaging modality for regeneration therapy. This is good for our country. This is good because it is cheaper than fluoroscopy. It is available even in distance city, and you can use it. You can help your patient if you know the technique. This is the regeneration therapy of the thoracic region. As I told you, you can use again curve probe or linear probe. Curve is better. You can see a spinous process, facet, transverse process, and rib in one view, and inject in all of these sites with playing with tip of your needle. This is very superficial. And you can check it in longitudinal view. And in lumbar region, you know, you can inject in every level, spinous process, facet, transverse process. I use a transverse view in one view and inject toward the spinous process, toward the facet, and toward the transverse process. In all of them, I have to touch the bone, and I will confirm that I'm in the correct position. This is the video of my injection. Look at this. Here, inject on the spinous process, and then move the needle up, play with the tip toward the facet capsule. Inject here, and then move it again up and change direction toward the transverse process. This way, very easy. And for SI joint, you know, there are many ligaments here around the SI joint. And you can see this video for many ligaments. Posterior sacroiliac ligament. Then look at the attachment to intermediate crest and lateral crest around the foramen. Iliolumbar ligament. Attachment is important because you have to inject all of this side. Here, 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 here. Even here and here. When there is instability in the sacroiliac joint, you have to inject in all of this side. Injection for sacroiliac, I usually inject in the upper part of the SI joint in interosseous and posterior sacroiliac ligament, and you can even inject into the joint, and you can even inject into the around the foramen in intermediate crest, lateral crest. You saw it was the site of the injection of the ligament. And this is video of the PRP of the SI joint. I enter a needle and they move it toward around the foramen, intermediate crest, lateral crest, play with the tip of the needle, and then move it toward the ligament, upper part of the SI joint. See how I play with the tip of the needle? I don't remove the needle at all because it's hurt the patient. Or the ligament. Consider posterior superior iliac spine and its acoustic shadow as a landmark for yourself when you want to inject in the fibrous part of the SI joint. And in a patient who has instability, it depends on the sign and symptom. You can inject in sacrotuberous and the sacrospinous ligament, and you can use the acoustic shadow of the ischial tuberosity and the ischial spine here for injection, like when you use injection for pudendal nerve. And for multifidus, the study that I show you, they use fluoroscopy, but you can use ultrasound very easily. Multifidus is up to facet joint in sagittal view and near to a spinous process in axial view. And you know, today's they use a spinal cord stimulator and enter a wire into the multifidus muscle because multifidus is very important. But why we don't use this cheap procedure? Just inject dextrose into the multifidus and repair it. This is great. And injection in sacrococcygeal ligament with this technique, transverse view and longitudinal view. Even when I had a patient that sacrococcygeal ligament was ossificated due to prolonged pain, 3 and 4 years, and then with injection of dextrose at this site came completely relieved. And there are good evidence for this kind of the therapy, but unfortunately, We need, this is not enough. We need more quality long-term randomized controlled trial, and we need more evidence about this kind of study. But as I told you, prolotherapy with dextrose, especially with ultrasound, is really a gift for our country. It is available, it is cheap, it is effective, and could improve the quality of life of our population. And whether to start with dextrose or PRP or stem cell is based on the severity of the physical finding, combining with the patient preference. Usually start with dextrose in 3 and 4 week follow-up, the 2 to 4 treatment to complete improvement that you desire, and then you can switch to PRP if it is not a substantial improvement, and you can use 2 or 4 treatment for 6 week interval. And if the result is good, you can repeat it. If it's not good, you can change to a stem cell, but the distance is about 3 months. And if the result of a stem cell is good, you can continue with PRP because PRP is cheaper. And about the complication, it is not too much. It's just the pain and swelling at the site of injection. It's the pain at the harvest site, low-grade fever, and the primary theoretical concern is about the tumorigenicity of the stem cells. Although in vivo and vitro studies show no result of the atypical cell in analysis, but because the study is not for a long-term follow-up, it's better to consider to don't inject the stem cell in patients who have immunodeficiency, immunocompromised, or have bone marrow cancer, or blood cancer and lymphoma. So don't inject a stem cell in this patient. Really, future of the regeneration medicine need more standardization, accurate nomenclature of description, classification, billing purpose, and to improve the science of the regeneration therapy. And for a good view about what really regeneration therapy do in degeneration, this is a look at this beautiful video.
Dr. Helen, 10 minutes.
Recorded lecture.
Okay.
This is 2 minutes to finish. Less to finish.
Thank you for your time. And ultrasound picture was from my book.
Yeah. Okay, Dr. Helen, that's finished now, and we'll go for questions. Okay,
Okay.
thank you so much. Dr. Talat will take you for the question. Dr. Talat?
Yes, yes, Dr. Saad. Thank you, Dr. Helen, for your nice presentation. That is very optimistically detailed and covers the pain management and the significant portion of people above 50 years, especially the low back pain and the spinal pain. There are two questions related to your lecture. You may let me to narrate this. From Dr. Mahmoud Al-Abd from Egypt. He asked about how many injections needed. I mean, how frequently the patient needs to be injected. And after this frequency, 4 sessions or 5 sessions of injection, the patient will be cured and he will not be in need for injections in the future.
But there are different data in the literature about how frequently you use prolotherapy, for example. Even you may see 2 weeks, 1 month, even you may see 1 time, 2 times, 50 times. But what I usually use is that for dextrose prolotherapy, you can inject after 2 weeks. After first injection, you can inject after 2 weeks, 2 to 6 weeks. But I usually ask my patient to come after 4 weeks and told them, what's the response of you? Are you satisfied with this kind of therapy? If they are satisfied, I repeat it. Usually I repeat for joint every month, 3 months. And if for a spine, usually even in literature, you see even 50 times you can use prolotherapy of the spine, but I usually use 1 or 2 times. First, because it is a little more expensive compared to the joint, and it is painful, and so it depends on your patient satisfaction. If your patient is satisfied with kind of therapy, you can repeat it. Even I told to my patient, when they are satisfied, satisfaction, is different between culture, between your patient. If your patient, maybe one of your patient is satisfied with 60% improvement, but one of them just want 100 improvement. So when the patient is satisfied, you can stop your treatment because it's not harmful for the joint or for the spine. But in a spine, it is a little more difficult. So it depends on your patient, but usually, for example, in joint, because about 15 years I use prolotherapy for the joint, I told to my patient after 3 times, anytime in your life, if you feel that you are not satisfied with your joint, you can return and do again 1 time at least prolotherapy as a kind of vaccination. They understand this. Right. So I have many patients who comes after 3 years, after 2 years, after 4 years, when they feel that they have some problem with the knee after prolotherapy, they come and they are afraid and they love this kind of therapy and ask me, please repeat it. We don't want to return to previous life that we have, low quality of life that we have. And prolotherapy is really great. After the COVID time, I start it for a spine. Because I really dissatisfied with the steroid injection. I don't like it, and because of the COVID, when the first time COVID started, many of the pain physician was very worried about the steroid injection. And today it's not the problem. But I start prolotherapy, and my patients are very satisfied. It's a great therapy. But you have to know when to start, when to inject. I usually do this with physical examination and find where is the most tender point of my patient spine, and inject at that site with the guide of ultrasound. And this is good therapy. I recommend you please use this for your patient because it really help old age.
Right, thank you. Another question from Manfredi Antioco. The question mentioned that what kind of patient could you try to regenerate? Middle-aged people, or when you have an old patients back and old patients with back pain, I think, and have some mechanical problems like stenosis in the spinal canal, spurs, and foramen narrowing at the nerve roots. Dextrose prolotherapy has a chance to work with these patients?
Yes, it has a chance, Manfred. I recommend you to watch my next conference in 12 March. This is about low back pain. And I talk about prolotherapy in different view in that conference, in those conferences in Mexico. And it is really effective. For example, when you have some problem, especially when you have pathogenic pain, it's very useful. When you have even a spore in the foramen, yes, you can inject in the foramen, but the only point that you must consider, Manfred, is that when you want to use dextrose prolotherapy for ligament and for joint, it is what is between 15 to 25% concentration. For joint, you can use 20 to 25%. For ligament, it's better to use 50%. But when you want to inject into the foramen, it's related to epidural space, you can use only 5% dextrose. And it's really good. Many of my students around the world, especially in Vietnam, if they are here now, told me, Helen, we are very dissatisfied with steroid injection in foramen, and we have only ultrasound. Can we use dextrose for radiculopathy, chronic radiculopathy? I told them, yes, you can use, and I show you evidence about use of the dextrose in epidural space in the foramen, and I ask you to try it. It's very safe and very useful.
Right. My question is, do you advise to use dextrose? Yes.
Yes.
It's agreed to use dextrose better than other injectables. But 5%, 10% or 15% or 50%, what is the best to start with?
For what?
For injections, for radiculopathy.
Radiculopathy, 5%. For radiculopathy into the foramen and epidural space, you have to just use 5%.
Yes.
But for ligament, it's better to use 50%. For joint, you can use 20, 25, even someone use 50%. But it's better to don't use it because it first produces an inflammation and it is uncomfortable for the patient.
Right. Regarding also the technique, you use the ultrasound-guided techniques.
Yes.
And I found in my hospital here and all over, I think they use the fluorotherapy. What is the best for the perfection of the procedure? Do the fluorotherapy has the upper hand over the ultrasound?
You know, in a spine, if you ask about a spine, for joint, you can use even blind technique. Joint is very easy. But for a spine, it's better to use ultrasound. Why? Because you want to inject near to the bone. And in ultrasound, every bone has an acoustic shadow, which help you as a cue to where you have to inject. And ultrasound also show you the soft tissue, the vessel. So in USA, for example, they are used to fluoroscopy. All the time use fluoroscopy for the injection, and they are more relaxed with fluoroscopy. They can use fluoroscopy. Yes, you can enter your needle toward the spinous process, toward the facet, toward the transverse process. But then you can use ultrasound. It gives you more confidence because you can see when your needle is passing through your gall. Okay. So I recommend to use ultrasound. Some even use this technique with blind technique. For example, Dr. Hauser, when started to introduce prolotherapy of the spine, they use blind technique. Even someone also use blind technique, but I think ultrasound is prior to every modality for prolotherapy of the spine.
Right. Thank you so much. I think there is no more questions. And Dr. Saad, we are ready to thank you, Dr. Helen, for your lecture, and hope to see you again. And Dr. Saad,
Bye.
yours.
Thank you, Dr. Helen. Thank you so much.